Everybody for joining today. My name's Jen Kovach-Bordnick, and I'm the CEO of the EHealth Initiative and Foundation here in lovely Washington, D.C. Welcome to the program this afternoon. We're going to be talking about using evaluation to drive SDOH program improvement strategies. A really exciting topic. I know a lot of people have heard about SDOH, and we're actually looking at the other end of it to try to understand how do you evaluate these things and really try to improve these programs. So this is great to know. This is actually one of the key principles that we developed with our SDOH principles about 3 years ago. So I'm really glad we're looking at the evaluation data piece of this topic. So welcome today. We have a couple hundred additional people who are joining us. So I'm going to go ahead and just start getting through some of the housekeeping items that we have today. Over in the chat box, if you're just joining us, let us know what programs you are running in your area and where you are dialing in from, or programs that you're interested in, so we can get a sense of where you are. We really want to know who's in the audience today so that we can address your concerns. For those of you who have questions, I'm going to go ahead. We've got a big group, so I'm going to tell you right now, if you've got questions, go ahead and put them in that Q&A box in the bottom, not the chat box, but the Q&A box, which is under the slides to your right. You see to the right or the left of the leave button, Q&A. So if you click on that button, you can type in a question there for the speakers, and we're going to get to as many questions as possible by the end of this session. The session is primarily going to really be discussions. So we want to get to as many questions as possible. Chat box is for you to tell us where you're dialing in from and tell us what programs you're from. Next slide. As I mentioned, we've got an incredible panel with us today. We're going to be talking a little bit about trends, policy, research, and mostly really focusing on audience Q&A. A number of you submitted Q&A questions in advance, and we're going to be talking about some of those in the first part of the program. Next slide. For those of you who are not familiar with the EHealth Initiative, we are a nonprofit celebrating our 20-year anniversary. And we're really a catalyst for healthcare transformation. We convene diverse leaders like we have here today from across the industry, and we're really trying to figure out how do you unlock those opportunities for innovation. And that's what we're going to be doing today. So welcome. Next slide. If you're not a member of EHealth Initiative, if you don't see the logo of your company up here, this is just a sampling of some of the groups that are actually a part of our EHealth Initiative Membership Leadership Council. And we would love to get you engaged. So if you don't see the name of your company up there, feel free to send me a chat through the box, or 1A and Sarah, and we will have someone on our team get back to you and talk to you about how you can get engaged. And SDOH is really a key priority for our organization. So if this is something you're interested in, I want to encourage you to definitely get involved in our work. Next slide. As I mentioned, SDOH is one of the top 4 areas that we look at. We also look at privacy, virtual care, and of course, COVID-19. We're all going to be looking at that for quite some time. Next slide. And we've got a wealth of resources available for you, all free of charge. So if you go to ehidc.org, there are a whole bunch of really fabulous reports that we've developed, guiding principles for the ethical use of SDOH. We've got lots of reports that we've done in the last year around people, how they are addressing SDOH, advancing health equity, our privacy framework, all kinds of great programs and reports available for you. Next slide. And I'd be remiss if I did not mention our Digital Health Equity Summit, which is coming up November 3rd and 4th. This is a virtual summit. So if you haven't registered, go to our homepage, ehidc.org, and please register. It's going to be 2 virtual days. You can pop in and out, but take a look at that agenda there. And I mean, just a stellar cast of speakers from all different vantage points of the healthcare industry. We've got payers, we've got providers, we have consumers, all different folks, researchers who are really out there in the field doing some pretty incredible work around health equity. So please join us. Next slide. And I want to thank, I'd be remiss if I didn't thank Lexnexis Resolutions, who's been with us from the start, really. From a few years ago when we started talking about SDOH, before SDOH was cool, when we were talking about ethical uses of SDOH data and how really to do this in a way that was appropriate and respectful of people. So I really want to thank them for all their support over the years. We could not do these educational programs without the generous support of groups like them. So thank you to them. Next slide. And as I mentioned, I keep referring to our incredible cast here. We've got a great group. We've got Andrea Green, who's the manager of healthcare strategy at Lexnexis Resolutions, and she's got a wonderful background in hospital settings, and you're going to hear all about that. We're actually going to pop their bios in the chat box here because all three of these folks have really wonderful backgrounds, but we don't want to take up too much time reading through them, or we would be here probably all afternoon, which is a wonderful compliment to the three of them. We have Kat Istis, who is the program and evaluation strategist for the American Academy of Family Physicians. Great background, of course, in that provider care setting and understanding a lot of the issues there. And she's going to speak to that piece of it as well. And then finally, we've got Monica Simmons, who is the Director of Advisory Services for SDOH at Lexnexis Resolutions. Really a wonderful background in community health and working with payers and running all kinds of programs at Humana and other places. Just really, I'm excited that Monica could join us here today. And if it's okay, ladies, I'm going to call you by your first name as we go through the session today. So I want to welcome all of them. Why don't we pop these slides out of the way? Great, here we go. We'll jump right in. And what I'd love to do first is just kind of go around and ask each of you, if we could. I think people are very interested in what kinds of models are actually working out there. And what are some successful models that you've seen that are actually using the evaluation data? And this is kind of a new thing. Not everybody's doing this. A lot of people are kind of slapping programs out there, but not looking at the evaluation piece. So I'd love to just go around and have each of you answer that question. Monica, why don't we start with you? You've got a breadth of knowledge and wealth of experience out there in the field, and tell us what you've seen in terms of successful models right out there right now.
Yeah, great question. Particularly when I think about our community health colleagues and those that are typically on the front line leading social determinants of health interventions from community-based organizations, what you really see is a centering of qualitative research, right? The opportunity to allow qualitative research to provide perspectives from those that may have lived experiences to get the narrative around whether the social determinants of health programs are really meeting the needs of the population. I've seen everything from pre and post test, from a maybe train the trainer model to do a knowledge check to see if the information is really resonating with the particular population. I've seen the stages of change being used, right? Seeing if you're able to move a population from that pre-contemplation, thinking about maybe making a change from a health behavior perspective all the way to action. So definitely seeing just the centering of qualitative research, even mixed methods, but really being able to show the narrative of mapping the social determinants of health interventions goals with seeing if it really resonates with the population.
Great, that's really helpful. That's a nice overview for us. Kat, why don't we jump to you next? What about in the provider setting?
Sure. So I think that social needs screening and referral really took off in federally qualified health center settings, and collecting patient information and demographics using some tools that at the beginning weren't as validated, and we're moving towards more validated tools and towards some more strategic measurements. There are a couple of programs that I would point out as leading the field here. Kaiser Permanente is doing a lot of work in this space. OCHIN, which is a federally qualified health center network in the Pacific Northwest, is doing a lot of work in this space. One I learned about recently is taking place in Hawaii through the United Health Foundation with funding from the Center for Medicare and Medicaid Innovation, which was handing the screening tool, which is a tablet, to patients in the waiting room to collect their information and then using that to connect them with social services. And that's the trend that we really see at the provider level, is collecting patient information directly from them and then using that to refer to community-based organizations. And the one model that I think has most promise for improving our ability to address social determinants and improving our ability to evaluate addressing social determinants is incorporation of an index into the patient health record that helps the physician understand at the point of care what the risk is for that patient based on their social context. So there are a couple examples of those. The Robert Graham Center has developed one. The social deprivation index comes out of the CDC. So there are a couple of examples of how those indexes can be used in the clinical setting, but that's really where a lot of this work is taking place on the provider side, is at the point of care.
That's fantastic. That's incredibly helpful. And we'd be happy to distribute any case studies or examples if folks want to share links in the chat box, or Kat, Monica, Andrea, I'll just give you guys an open invitation because we are certainly going to get questions where people want more information about those programs. So we are welcome. We will distribute those if you want to share those. So thank you. Andrea, how about in the hospital setting? Tell us about that.
Yeah, so in acute care, really, there's a lot of focus on length of stay and looking at how you can potentially reduce that length of stay. And what we've seen is transportation data and social isolation data, particularly in how it relates to length of stay, can be really impactful, because we've got, depending on geographic location, anywhere from 20 to 60% of patients lack transportation, right? And so when you're starting discharge at day one, you're really thinking about how can your patient get home. And if there are barriers to discharge, if there are particularly transportation, that means barriers and delays in getting them kind of out the door. And this, of course, can have some cascading effects, right, within your organization and your operations, because then you have a bed that's getting taken up and you have patients that are waiting for that bed in the ER. So really being able to identify kind of at the point of entry who might be struggling with transportation or social isolation, and being able to intervene. So providing transportation vouchers or partnerships with certain transportation companies like Uber or Lyft. But I think it's important also to not just look at, when it comes to evaluation data, right, not just looking at kind of the cost of transportation versus the cost of the length of stay, but also looking at detailed information throughout that kind of PDCA cycle, right? So looking at how many rides are being offered and how many rides are being accepted, because that, I feel like, it's a much clearer path to determining what those barriers are. So it may not necessarily be a ride per se, but it might be, is there somebody at home that can take care of those patients when they get home? So really being able to look at your programs holistically is going to be really important, especially in the acute care setting, when you're looking at length of stay and, the hours matter, right? You have these very specific DRGs. So even a few hours can affect the hospital's bottom line.
Yeah, so those are really great data points and metrics, Andrew, that you shared with us. And Kat, I know you mentioned a lot of patient-reported data that is being used there. Monica, I just wanted to give you a chance to kind of add on there. What are you seeing with payers and community health?
Absolutely. Yeah, one of the things that I try to kind of challenge or allow people to really think about is creating a bit of a comprehensive evaluation program. So you want to start off really at the patient level or the member level, right? Looking at either quality of life indicators. We've also seen in the payer space the use of the CDC Healthy Days measure. You may want to again look at stages of change, some of those more detailed one-on-one measures to get a sense of how the interventions are impacting the population at the individual level. From there, you really want to transition more on the operations side. So that again will be similar to the number of referrals. You can look at the number of individuals that were served. You can look at your call time, your connect rate, more of an operational perspective. And then finally, you go to the measures that we more traditionally think of are outcome measures. So that can be ER utilization or length of stay. And then the final item that I really have like for individuals to think about is more of the organizational level and the downstream impact. Through the use of the social determinant of health intervention, how are we able to impact our care gaps, our HEDIS scores, even our customer experience. So when you have the evaluation plan at the individual level, the operational level, the outcome level, and the organizational level, it allows you to be able to present a stronger case and even get closer to the ROI goal that you may be looking for.
This is, I mean, I think this is really helpful. As I can see in the chat box, people are loving this. Other evaluation data points, Kat or Andrew, that you want to share that you think would be helpful to people? Or types of metrics that could be used in the evaluation?
Sure. So, I mean, the purpose of the evaluation in general is to improve the effectiveness of a program or policy. So you want to look, I think that what Monica said is absolutely right. You want to look at the sort of outcomes evaluation, the process evaluation, and maybe even deploy some developmental evaluation tactics as the program is still in its infancy and developing and evolving. So there's a couple different spots along the pathway of connecting patients to a referral or a community-based organization. So there's getting information at the point of screening, identifying the patients with those social needs. Then there's, how the healthcare organization refers to the social resource. So the connections that they have can also measure at the point that the participant connects to the social resource. So how many of those referrals actually made the connection. You can find out then how many of those participants that made the connection received the resource, and finally, how many of them actually had their need met. So there's a whole continuum of ways that you can measure when you're looking at social determinants of health and referrals.
Mm-hmm. Anything you want to add, Andrea?
No, I think that's pretty comprehensive explanation.
Okay.
I think, just making sure that you understand that evaluation, can come in many different ways, and success metrics can be measured in many different ways. And you really need to make sure that you're doing it kind of multifaceted.
So one of the things I'm interested in is, how does an organization think about this when you're doing really a large scale evaluation plan? So how do you handle this? So what should organizations be thinking about if they're getting ready to launch this on really a broad scale? Monica, could you jump on that first?
Yeah, absolutely. So the first thing I like to say is really thinking about, who do you have at the table, right? So when you're designing an evaluation plan, we often think about having our clinicians at the table. Also think about social workers, individuals that were trained in health behavior and health education, individuals that are really trained in more of the data science, right? So you have a holistic view of, can we design a evaluation plan that not only focuses on the outcomes, but allows us to make those improvements throughout? So that's the first thing I would say. The second thing I'd say when organizations are thinking about large scale evaluation plans is, you can't do it alone. There really is a huge need and even an expectation from the market around partnerships. Unfortunately, one of the challenges that organizations may face is the wrong pockets issue, right? So an organization that may be putting in the initial investment for an intervention may not see the outcome or benefit from that another organization or entity may. So when you're having more of a holistic evaluation plan, you have other individuals that are at the table, that may allow you to think through what other organizations or agencies may benefit from this intervention that I could partner with, and they could be a bit of a win-win situation. They're able to move the needle on their metrics, and we're able to move the needle on our metrics as well. The other item that I would really challenge organizations to think about at a large scale, I think we're very comfortable, particularly for my payer colleagues, with our claims-based analyses, with moving forward with looking at outcomes and large scale analyses. But again, focusing at the individual level, are there ways to measure quality of life? Are there ways to see how their intervention may be impacting self-efficacy? All of these items are predisposing factors that can influence the health behavior that starts that chain to improve the overall health outcome.
Great, that's really helpful. I mean, let's talk a little bit about kind of accessing some of this data, because we know that there are a lot of barriers to collecting and accessing the data. And I'm curious, Andrea, if you could address that, what do you see as some of the biggest barriers and strategies to overcome them? Except you're on mute. There you
Yep,
go.
there it is. It's going to happen at least once. So I think some of the challenges that a lot of organizations face when they're trying to find data or trying to figure out what data they want to use is maybe they're not necessarily sure of what population that they want to target. So being able to know what what problem you want to focus in on and what population you're targeting, I think is going to be really important. And then also making sure that you have reliable data sources. Survey data, of course, needs to be part of the process, but making sure that you understand that survey data can often become stale very quickly, or maybe there are patient-reported information might not be necessarily reliable or accurate. There might be omissions, for various reasons. And sometimes organizations would like to use census data or free publicly available data as well within their data sets. But just keeping in mind that sometimes that data set can kind of be a little bit older, up to 10 years old even. And, sometimes that data has been aggregated or even jittered for, anonymity. I can't say that word. Anyway, yeah. So those are kind of some struggles. Exactly. These are some of the struggles that you might be finding when you're looking at what types of data sets that you're using, and then also trying to decide again what problems you're focusing in on. Are you going to combine large data sets with clinical data? It really depends on what your focus is and what problems you are trying to address.
Yeah, Monica or Kat, you want to jump in on that? Biggest challenges around collecting the data?
Yeah, I think one of the biggest barriers to evaluating social determinants of health outcomes is that the nature of the data is so siloed among community organizations, and the health sector really benefited from the HITECH Act and the digitization of health records. And that benefit of funding and capacity building were not extended to the social sectors. So a lot of social health information has not been digitized, and the infrastructure for community-based organizations needs to reach a level where it can coordinate with health records and electronic health records. So the CARES Act more recently did allow improvements in the electronic health record, including the ability to function with APIs. So I think that allowing electronic health records to interface more frequently with community-based organization data sets is going to bring us a long way in gathering information needed, and then also reporting and understanding what outcomes are coming out of these collaborations. So the measurement part is really important. But one thing I do want to mention is as far as one of the reasons that we want to work on social determinants of health and improve social determinants of health is to improve health equity outcomes, to reduce disparities. And to that end, it's important to consider what the needs of the community who are most affected by those interventions are. So including them at the table is becoming more and more important, especially when we're talking about measuring outcomes based on patient-reported data and health outcomes. So including the community and really identifying the community that you want to have an impact on, and then including members from that community in your evaluation process is really important for an equitable outcome.
Yeah, Monica, could you address one of the items that she alluded to, which was kind of the sharing data and the claims data, and how do you kind of foster that or overcome that? What are some strategies there?
Absolutely. So I would say one of the first things, particularly for my community-based organization leaders, really to focus on establishing those partnerships with payers, being able to talk about what are some of the social determinants of health interventions that you're looking to roll out, talking about your population that you're looking to serve, and reaching out either to medical directors or the directors of quality improvement, even the heads of analytic organizations, talking about the opportunity for a win-win perspective is really, really the direction to go to encourage equitable and safe data sharing practices. One of the things I wanted to emphasize as well too, a challenge, particularly everyone can see this with the pandemic, right? Just being resource short, overburdened, really wanting to be strategic and more efficient when it comes to rolling out surveys. So one of the things I suggest individuals think about is how can you use a survey question or an evaluation plan in a multifaceted way? So for example, if you're in a community-based organization and you have grant funding obligations, are there ways to leverage your questions to look at cultural competence or look at access to care or look at stages of change, right? So we understand that you may only have a certain amount of time with your population and you want to make the most use of it. So just thinking holistically about how to be efficient with how you're rolling out the evaluation plan. That's something I really wanted to lift up because it takes a lot of work to roll out something that's comprehensive, and really being resourceful is the key.
That's a great point. And Kat, I want to go back to you for 1 second, because I know you're doing a lot of work and research around evaluations and trends, and you've been researching this across the country right now. So I'm hoping you can kind of share with us, what are some of the trends that you're seeing in evaluations right now?
Yeah, so again, I think evaluation outcomes, like health outcomes, are really difficult to measure, especially when we're not using synchronized or standardized tools. So for example, if we're looking at the outcomes of improving needs, improving food security or transportation or education, employment issues, a lot of that information requires partnership and collaboration to get outcomes data on that. So it's really important to form those partnerships locally in your community and even nationally with some of the more, some of like the larger health data partners that we have. So I think addressing outcomes at this point, the trend is to look at process outcomes. We're seeing a lot of process outcomes in the literature, like how many people are we screening? How many of those screened are being referred to an agency? And what we need to move towards is understanding how our programs are having an outcome. And those are going to be on things like rehospitalization rate is a really big one. Rehospitalization rate and reducing rehospitalizations is an outcome of interest to many health systems at this time, and especially in employing social determinants of health strategies. So I would say that's a really big one. And then another one might be, another trend is specifically targeting a disease category. So we might be looking at just people with colon cancer, for example, or just patients with asthma, for example, and trying to make an impact. And I think that's what Andrea was mentioning when she was talking about like zoning in on a specific population for this work to make sure that your outcomes are measurable. And I think that's a really important part of the evaluation process.
Andrea, can you expand on that a little bit in terms of what's happening in the industry right now? What trends you're seeing, but also are there regulations or policy developments that are happening in the industry that organizations need to keep in mind?
Yeah, sure. So, back to kind of that clinical connection. So if you're looking at readmission rates or rehospitalization with patients with COPD or CHF, there can be a lot of different factors to that, right? So we have some predictive models that have shown that patients that have had multiple phone numbers and multiple addresses are at the medium risk or high risk for readmission. I think the Z code expansion is going to be really important for this because, right now Z codes are really underutilized and kind of inconsistently documented. And if there aren't really clear reimbursement guidelines, it's kind of hard to get everybody on board with this with standardized approach at documenting some of these SDOH barriers. So the Gravity Project, I think, is something that we really, everybody is paying attention to, everybody really needs to pay attention to, right? So an example of that is homelessness. So going back to those readmission rates for certain patients that have had housing instability. So right now, Z codes allow you to document for homelessness, but there isn't a Z code yet for risk for homelessness. So as kind of the industry starts to develop and these types of Z codes and documentation, standardized clinical documentation within the patient's record is better utilized, I think that we'll be able to identify risk at an earlier stage so that you can then intervene and address those barriers kind of quicker to help patients, address their housing instability or that risk for homelessness, and then that can also help with their admission or their readmission rates.
I am curious, before we dive into some of the participant or attendee questions, and we're getting a lot here, guys. I see them. I'm going to get to them in 1 second. We're almost there. But there's been so much talk about SDOH and health equity. And I would just love for you guys to weigh in on this. I know we're having a health equity summit in a couple of weeks, and certainly SDOH has been an area that many organizations have been focused on. Can you talk a little bit about the difference between them and how you think they're related? And Monica, why don't we start with you?
Yeah, sure. So when thinking about like health equity and social determinants of health and even health disparities, I try to visualize it in 3 columns. So health equity really is the goal of everyone having the potential to achieve their maximal health, right? So that's the goal. That's what we're all working towards. Social determinants of health is a vehicle that can be used towards that goal. So if you're focused on housing insecurity or financial stability, right? A vehicle that can be used towards achieving health equity. And health disparities, that's more of a measurement, basically to see, are we meeting the mark in terms of overall health equity? One of the things that I really want to center as organizations are making a commitment to health equity, really looking at researchers or community-based partnerships or programs that have done the work for years, right? You want to be able to leverage and center individuals that may have had lived experiences in this field, and have really devoted their life to this work will be really helpful and really important as we move forward.
Andrea, anything you want to add?
No, I think that's a really great way of looking at it kind of in those 3 columns, because SDOH is really just a small part of helping to reduce those health disparities, then to make sure that that health equity is kind of on the horizon, right? So we really have to make sure that we're paying attention to these tools in our toolboxes, but not necessarily rely solely on just the data. I mean, you're going to get the data, you're going to see it, but then you need to figure out, then so what? Now what? How do we get to where it is that we need to go?
Yeah, and Kat, as a researcher, are there specific things in terms of talking about these 2 topics and how they relate that we should be aware of?
Terminology gets kind of sticky around these things. So most of my research is focused on social needs screening, which are related to the social determinants of health. Those social needs might fall under the domains of the social determinants, like food security, nutrition, transportation, education, employment, housing. So I think it can be challenging to get your head wrapped around these separate definitions. Monica did a really great job by placing them in 3 separate columns. And ultimately, I agree that social determinants are the vehicle that get us to health equity. So the most recent research that I've read shows that health outcomes are only 10 to 20% due to the medical care that you receive. The other 80 to 90% is based on your neighborhood characteristics and your social determinants. So a lot of meeting that health equity gap is going to take place in the space of social needs and social determinants.
Great. Well, I'm going to jump to some of the audience questions here, and then we'll go back at the very end here for some closing thoughts from each of you. But number of questions here. Andrea, I'm going to take this first one to you about, you were talking about kind of diseases and focusing specifically on diseases. Is there a list of standardized social determinant of health, data points across per disease entity, or any groups that are, a good resource for that?
Yeah, so the answer is no. And the reason is because every data set and every patient population is very unique. So what you really want is to not be afraid to let the data speak for itself, right? So you can have a target that says, I want to, my organization is going to focus on pre-diabetics or type 1 diabetes. And if you're not looking at your data kind of from this wide lens, you can sometimes miss the cues that are in there. So if you are able to have an analytics team or have a strong data science team, they'll be able to look and see how certain SDOH attributes might be correlated to certain health risks. But that all has, that's an iterative process that's done through statistical modeling. And so I wish that I could say that, housing instability plus phone plus transportation equals this, but it just doesn't work out that way. And it's because there are human lives behind each one of these data points, and everyone is unique. So I think my advice would just be to look at the data that you have when you're trying to figure out what types of goals that you want to reach or what problems you're intending to solve.
Great, thank you. Monica, so I think we learned during COVID that a lot of the data from community organizations and public health was, collected manually or was not available electronically. And a lot of these groups are just severely underfunded. Hopefully, all of you can work with us to try to change that moving forward. But can you talk a little bit about, in your experience, what types of data is available electronically that has been able to be incorporated into some of these efforts?
Yeah, absolutely. So I think the first question I would ask is, at what level are you speaking? So if you're thinking more from a neighborhood or a geographic region, often the go-to is census data or leveraging the American Community Survey data, right? So more at a holistic level. If you're speaking individually, at LexisNexis, we do have over 442 attributes that allow you to have clinically validated social determinants of health data. But it's really just drilling down to get a sense of, again, what's the level? Is it more individual? Is it at the geographic region? Is it a particular disease state that can help? Another resource that I wanted to share as well, the Commonwealth Fund has released an ROI calculator that allows you to put the inputs for certain utilization, expected expenditure related to social services. So that may be a tool as well for community-based organizations that may be feeling the brunt of having to build a business case amid COVID-19, the pandemic. And I would also recommend community-based organizations try to partner with local public health departments in the area as well too, as a way to do data sharing and fill in some of those gaps. And again, healthcare, seeing if you can establish those partnerships.
Great. And if somebody wants to pop the Commonwealth Fund ROI calculator into the chat
Sure, I'll throw that in there.
Got that on their favorites, that would be great. Oh, somebody's already done it. I love having this. Great. Super. Kat, so talk a little bit about some of the, in the provider setting. So are there, financial incentives or medical decision making? Do you feel like any of those are providing financial incentives right now for SDOH risk factors? Do you think that I know we're collecting some of this data now in EHRs around the country. Do you think that that's helped kind of increase the documentation there? What can we do to beef this up?
Yeah, so those are really good questions. One report that I would point to is Deloitte published a report in the last couple of years that reports on a survey of 300 hospitals, which is nationally representative sample in the United States, that found that over 80% of hospital executives are interested in investments in social determinants of health. And our own AAFP's own surveys have indicated that over 80% of physicians are screening for social needs at this time. So there's a huge interest in doing this work at the clinical setting. What we need to do, I think, is make it a little bit easier to get the information on the back end for population health management and neighborhood level characteristics. So it's not enough to put the information into the EHR from one of those validated screening tools. We also need to combine it with neighborhood level information or the social deprivation index or another type of indices that tells us what the risk is of that patient based on the neighborhood that they live in. And there's two sides to that coin. Obviously, there's a risk of an ecological fallacy occurring there where a patient is healthier than their neighborhood characteristics. And there's also, some issues with bias that come into play at that point. But there are a lot of tools that are starting to work using that API integration into the EHR to get more information into the point of care information that's available to the clinician. Another resource that AAFP has that I would point to is Health Landscapes, which is a free GIS mapping tool that allows anyone that wants to use it. It's an open source platform. Anyone that wants to use it, look at all the way down to zip code, but census tract level data. So including applications like that and including new sources of data or aggregated sources of data is really what's going to get us to scale up these operations.
Okay, great. This is spot on, guys. They are loving you in the chat box. So I'm going to keep going with these. Andrea, so a question about, discharge. So in terms of discharging to home, are they starting to accommodate for these in-home assessments? Are you seeing mobility assessments for people? Can you talk a little bit about that, or environmental assessments for respiratory patients? How are those being included right now in evaluations?
Yeah, absolutely. Evaluation happens at the point of entry because you start planning for discharge on day one, right? So not only are case managers looking at, if the patient is going to be able to go home or if they're going to have to go to rehab. Of course, patients, we always want to send them home. They heal better that way. But they're also looking at, are there stairs to get up into their front door? Will they be able to have access to home infusion or respiratory care? Or if they have transportation struggles, can we get them PT, OT in the home instead of having them, having to go out multiple times a week? It's the same with, if they're having blood draws and they need lab work continuously done because they're on Coumadin or something and they need, their PT-INRs drawn twice a week. Can we do it in the home if the patients can't get to where it is that they need to go? So that type of evaluation is always done in the acute care setting, and there are multiple different tools that are that case managers can use to make sure that they have this bigger picture. You don't want to just look at LACE scores or hospital scores to look at readmission risk, but you also want to evaluate whether or not patients have access to medication and will they be adherent with their medication. Our CHF patients are so fragile. It can be like one potato chip or one Chinese takeout meal that can get them back into the hospital if they're not taking their medication regimen really specifically and as directed. So making sure they have access to that medication and they have the knowledge and the education to remain adherent are all things that really need to be considered prior to discharge, and it's part of that whole discharge process.
Let me just add on to that. And Monica, this question is for you as well, but Andrew, why don't we start with you? There are a lot of community-based organizations that feel like they have a lot of experience in this area and they really want hospitals to utilize their services for case management. How can that happen? What's the best way for that to happen?
I think having a referral loop is really important. I think Kat has talked about that, the importance of that closed loop referral, and making sure that hospitals and healthcare systems are able to reach out to those community-based organizations and coordinate that care with them. These CBOs really have great insight on their communities. They're connected to their communities. They know the people that live there, and that's a really great way to have patients trust them, when they're trying to provide education or services, and it's going to help drive up that utilization instead of oh, no, thank you, I'm not really comfortable. It's like, oh yeah, I know her, or I know somebody that has used this before, and that's really helpful. So I think making sure that you have that relationship with those organizations, and you have somebody that can drive that relationship between your healthcare organization and the community-based organization. That's also very important.
So Monica, as you've worked in the communities, how have you seen this, these groups able to actually hook up and make this kind of a more formal arrangement?
Yeah, I think the first thing for community-based organizations really is, again, like knowing the value add and the worth that they bring. Just like Andrea mentioned, being able to have that built trust, understanding lived experience, and even just overall being able to have cultural competence and tailored intervention is absolutely a value add. So one, I would say, again, reaching out to maybe medical directors, directors of quality improvement, kind of looking at, particularly with the shift on how social determinants of health and community outreach programs have started to combined with health equity initiatives, looking at who may be leading those organizations and reaching out to have a conversation on what type of arrangement may be a win-win situation. So whether that's a value-based arrangement or again, ways that multiple entities could come together to achieve the goal of health outcomes. The other other entity that I wanted to highlight are our researchers and our academic institutions as well too. I think we all can attest that at the end of the day, having an ROI or evidence-based research added to the literature will benefit all of us. So thinking through partnerships that include community-based organizations as well as payers or providers of health systems, along with academic institutions, really creates a strong trifold bond.
That's great. Really great points. Back to you, Kat. So you've done a lot of work in terms of how these different elements are being incorporated into SDOH. One thing we haven't talked a lot about is behavioral health. And I'm just curious, what trends and how often you're seeing that incorporated in some of your research, because I think that's a really critical area that we don't talk about enough, but it's something that we really need that piece of data and for the providers to understand that.
Yeah, and I think behavioral health integration is a really good model for demonstrating how social determinants integration, social care integration can happen in the healthcare system. Because behavioral health integration has been a trend in most recent decades, and getting mental health providers into primary care clinics, into hospital settings, and integrated into the care team has been really important. And the same thing now is happening with social workers and community health workers. The AAFP especially encourages social determinants of health work to take place in a team-based setting and team-based care model. And that's really important for not putting the burden onto providers for more of this work. But it also helps because they have more expertise. Social workers have more expertise in connecting to community-based organizations than healthcare providers would. So it really does take a team model to care for behavioral health patients in the primary care setting and for social determinants care in primary care setting.
That's great. One thing, actually, let's just follow up on this a little bit. So this is an interesting question. So do you think that the SDOH data collection, is that limiting the potential or the belief that an individual can actually have a good health outcome? The whole idea that someone is kind of in a category and that how can we kind of change the path?
I think that points to a concern among researchers in this area that social needs will become medicalized in the same way that medical needs are. But I don't think that should be a reason to not collect information on an individual patient basis, because we just don't have we don't have integration of data in a way that allows us to get an individual perspective of what a person's social needs are. So at this time, we need kind of both measures to meet in the middle. We need the neighborhood level data and we need the individual patient data. I think that there's a lot of work being done, especially by the CDC right now, to look at de-identification methods for data integration. I think that's a really important topic to bring up when we're discussing screening for social determinants of health. We don't want to stigmatize food insecurity, for example. We don't want patients to feel that they can't share their social needs if they're houseless or if they don't have a permanent living situation. We don't want to stigmatize that to the provider. We want to allow privacy for the patient. So de-identification methods are becoming really important in data sharing.
Great, that's helpful. Monica, let's talk about planning data collection. And I know that there's been a lot of stuff going around in the chat room, but I'm going to ask you anyway. Are there any specific data models or common data models that you would suggest around data collection?
Yeah, great question. So the first thing I would say is, again, kind of look at your team, see if you're able to include someone that has a background maybe in health education or behavior. There are models such as intervention mapping or the pre-seed proceed model. or even logic models to help you think through the elements of the intervention that you're looking to deploy, and then mapping the evaluation elements to the ultimate goal. So that's the first thing I would say. Again, back to the framework I mentioned earlier, looking at the information at the individual level. So whether that's CDC, the Healthy Days indicator, or the quality of life indicators, you want to start there if possible. And then operational evaluation. Someone in the chat asked for me to go over some of the metrics, so I can list those. They can range from the number of unique outreaches and attempts that you're making versus the success rate you're able to make with your population, the number of unique resource referrals, the number of overall unique individuals that are served, the number of unique individuals that are screened. I saw a lot of chat about the prepare screening. So yes, that is something that organizations are not only using and deploying, they're using that as the foundation to think about what's the particular barrier that they want to focus on for their social determinant of health intervention. So I wanted to just lift that up as well too. Other metrics at the operational level may be just the top presenting needs by resource category and the point of service. So your post-ER visits or post-discharge as well too. And then finally, I wanted to highlight, there was a question about some of the program outcomes or ways to tie it to organizational outreach. So one is related to like readmission, total cost of care, length of stay. And then again, thinking about how the social determinant of health intervention may be impacting care gaps, HEDIS scores or CAP scores, and even customer experience as well.
Excellent. That's really helpful. Let's talk COVID. We haven't talked, it's already 50 after the hour. We haven't even talked about COVID yet. Can you guys talk about some of the SDOH data models, research that you've seen based on COVID? I'm guessing in the hospital. Why don't we start with you first, Andrea? What kind of work have you seen around SDOH and COVID?
Sure. So, you know, pandemics, we've known that pandemics have disproportionately affected the poor, people of color for forever, right? And COVID is no different than that. So what we've seen with our statistical models is some changes because of looking at risk adjustment, where you're looking at claims data. Monica can probably speak a little bit better to this, but because patients have not been seeking care as often, or, you know, we don't have as many elective procedures, or there was a period of time where elective procedures weren't even being done in many hospitals across the country. You're lacking that robust claims history and that claims data to be able to really figure out how you're going to do your risk adjustment in the payer space. And then also the data around social isolation, I think, is really important. So, you know, during COVID, where everybody kind of needed to kind of hunker down and stay in their own spaces, it's really affected patients' behavioral health, because social isolation, we know, is a large contributing factor to mental health illnesses, and even suicide risk, substance abuse. So those are all things that we try to take into consideration when we're looking at our statistical models, and when we're looking at our data, is looking at household members and nearest relatives, and how far away somebody might live from their nearest relative or associate. And because Lexnexis has like this very robust data system and linking technology, we're able to see that within our data sets and make sure that our models have been adjusted for that. So I think that we cannot really talk about COVID without talking about social isolation and how that has affected people, you know, mentally. Yeah.
Anything you want to add in terms of what you've seen around the developments with COVID and SDOH research?
Yeah, so the case study that I mentioned coming out of Hawaii, the United Health Foundation, funded by Center for Medicare and Medicaid Innovation, did find that their social needs screening tool found an uptick in needs for food security and also utility payments, and then also domestic violence issues increased during the pandemic. So having a social needs screening program in your hospital health system or clinic can help you identify when things are changing for the worse, and start push for policy changes. So there's really an advocacy component to this as well. Advocacy, taking the information that you are seeing from your screening of local populations and sharing that information with local governments, whether there needs to be a freeze or a stay on utility payments, or more support coming from those types of industries. Advocacy goes a long way when it's bolstered by information, and this is a good source of that information.
Yeah. Monica, as someone who worked on the provider side and was supporting employers, we've got a great question here from a purchaser who wants to know, how can they influence change in the healthcare marketplace? So how would you advise employers to kind of incentivize health plans or providers to collect and evaluate SDOH data? So what role can they play?
Oh, absolutely. With us talking about the pandemic, low-wage workers were some of the individuals that were hardest hit, right? When you think about behavioral health needs, I think employers can start off by conducting a bit of a needs assessment, understanding what are the social and mental and emotional needs of your employee base. From there, if you're able to incorporate even qualitative research, doing focus groups, getting a bit of that narrative experience, you're able to help to develop a business case around the importance of focusing on social determinants of health in the employer market. And we're starting to see that at some of the large payers, there's more, even more heightened emphasis about just the health of employees. One of the things that I did want to highlight as well too, with the pandemic, one of the things that we saw at the congressional level was the formation of the Congressional Social Determinants of Health Caucus. I don't think that has been brought up, and just a bipartisan initiative around social determinants of health. So we're seeing a lot of activity there. And so again, when we talk about advocacy and the opportunities for impacting social determinants of health, it's all at the policy level as well.
And what do you guys attribute kind of the lack of integration between health and social services? The ability to really share that information back and forth. Is that kind of a connectivity issue? Is it a data sharing issue? Is it a privacy issue? What do you think that the major barrier is there? Kat, do you want to address that?
Yeah, I think it's all of the above. That there's a ways to go. Community-based organizations that are accepting referrals from health systems and hospitals haven't had to deal with HIPAA issues as much as health systems have. They don't have that capacity in their data infrastructure. So I think a lot of community information exchanges are starting to take that into account. And I think that a community information exchange is really sort of the doorway to get us to the next step, or like the stepping stone to get us to the next step of interoperability between health systems and community-based organizations. So we really need a centralized model for information repository that can be de-identified, but also have information shared and close the loop on those referrals back to the health system so that they know that their patients are having their social needs met.
So we've only got a couple minutes left, so I'd love to give each of you an opportunity to just share some final thoughts in terms of what we really need to advance the evaluation further. I mean, what can organizations do? What are the kind of the key steps and things that they need to do if we want to push the envelope here a little bit? So I'm going to give you guys a minute to think about that. Any volunteer to go first? Okay, Andrea.
Yeah, I'll go first. I'll go first. Sure. I think it's trying to keep it simple, right? You can definitely get analysis paralysis, and when you're dealing with data, especially large data sets, it can be really overwhelming, and you can get overwhelming very quickly. So my suggestion is to identify your problem. That is going to be your very first step.
Great. Excellent. Kat?
Sure. So my dissertation work is developing in this area right now, looking at how the hospitals, clinics, and federally qualified health centers in Kansas City, Missouri are coordinating care around the social needs. So we're starting from the point of how are you screening? How are all of these health systems screening? And can we get that screening in alignment? So are we using different screening tools? And are we using different criteria for screening our patients, which is really important if some are just screening those that are under case management versus those that are inpatient versus those that are being seen in outpatient clinics. So I think starting where you're at means getting information that's already available from those partners that are already around you. So starting kind of small, like Andrea said, get an understanding of what's going on in your current environment. So there's a reason that a lot of these social needs screening programs, social needs referrals programs, and intervention programs are taking place in different metropolitan areas, taking place in health systems exclusively. And it's because this opportunity for sharing is really difficult to overcome. So start small and ask people what information they have and how you can share it, and incorporate big data sets, like BRFIS or MIPS data when it becomes necessary, not as an origin or starting point.
Okay, Monica.
Yeah, I would say thank you for the work that you're doing, because I know this is a lot. And so just kudos to all my colleagues that are on the line. And my final point would just be open to partnerships. If you're a community-based organization, understand the value even more that you bring, and being able to maybe develop that business case to partner with providers and payers. If you're doing it alone, reach out and see, are there other organizations that I can leverage my funding and my capital and my resources to help as well. We can't do this alone.
Excellent. And I do want to let folks know about our LinkedIn group, because there's so much good conversation discussion here. So if you go to SDOH and Health Equity Warriors, love that name, 1A, please join the LinkedIn group and we can continue this discussion there. We will post a number of these links there, and some of the questions, that's SDOH and Health Equity Warriors. Please join that group on LinkedIn. And I really encourage you to continue the discussion. I do want to thank Kat, Andrea, and Monica. I told you this was going to be just an incredible, amazing discussion. Thank you for your thoughtful responses today, and for participating. And thank you to all of our attendees for sharing these resources. We will send them out again with a link to the recording. So please share that information. We need the information to go out as much as possible. This is a critical area. So thank you everyone today. Thank you LexisNexis, and we'll see you next week at the next one. Take care, everybody.
Thank you.
Be safe.
Thanks everyone. Bye-bye.
Bye guys.